earned Thank you. Earned her general medical degree and master's in OBS and Gyne degree from the University of Nairobi. She then earned a certificate in international health, a master's in public health, and a PhD from the University of Washington's Department of Epidemiology, a postgraduate diploma in research ethics from the University of Cape Town, and a master's in bioethics from the Center for Bioethics and Culture at the Sindh Institute of Urology and Transplantation in Karachi. She is a certified IRB professional. She's a senior principal clinical research scientist at the Kenya Medical Research Institute, a research professor at the University of Washington, and an honorary lecturer at the Aga Khan University in Nairobi and Maseno University, and a volunteer clinical faculty professor at the University of California, San Francisco. And all of this is in the Department of OBS and Gyne and Reproductive Sciences. Prof. Bukusi, in collaboration with Dr. Craig Cohen at UCSF, established the KEMRI Research Care and Training Program in 1995. In addition to her substantial experience in conducting socio-behavioral and biomedical research and providing HIV care, she mentors and trains healthcare and research personnel to enhance local and international capacity. She also has a strong interest in research and clinical ethics and the development of systems and structures for regulation of research at KEMRI and in the country, and this is when I met her. She was the chairperson of the Bioethics Society of Kenya, a multidisciplinary, non-political, non-discriminatory, and not-for-profit organization with the primary objective of promoting high ethical standards in biomedical research, medicine, and healthcare in Kenya. She is a board member of AVAC, chaired the WHO-HRP Alliance 2016 to 2021, and is a trustee for the HIV Trust and elected fellow of the African Academy of Sciences. So please join me in welcoming Prof. Bukusi. She's been my mentor. Prof, I've just realized I've been in KEMRI for the last 20 years. So we've known each other for about 20 years. And I've known you to be a very dedicated and focused person when it comes to particularly HIV research. I think you've done quite a lot in that field. Thank you very much and welcome. This is to go until 3:30, Prof. So I don't know whether I should stop you at 3 or 3:15. You tell me so that we can have the questions.
I'll try and make sure that I finish before it is 3 o'clock, so that if it is finishing at 3, that we'll have some time for people to ask questions. So good afternoon, everybody. And those of you who have not met in person, who are probably the majority of you, given there are over 600 people online, let me start by wishing you a peaceful, productive year in 2024. I hope your dreams will come true, and I hope that you'll be able to realize whatever you want to achieve this year. You're not able to see my video right now because the host has disabled the video for now, but later on, perhaps you'll get a chance to see what I look like. So I will be sharing with you this afternoon, and it's going to be my privilege and honor to talk to you about public health ethics. My other 2 colleagues, Caroline, will be talking about research ethics later in the week, and Professor Muhudia will also talk to you about clinical ethics. So I want to acknowledge upfront people whom I've been working with, whose slides I have borrowed from generously, and the KEMRI Bioethics team who work on this, who have generously given up their time and effort to ensure that we can do this work in promoting ethics. And of course, I'm also grateful to the Director General KEMRI, who has enabled me to be able to be part of this training. So the host has enabled video. You can see what I look like now, but maybe so that I don't distract you, let me keep my video off and I'll bring it back on when it's time to answer questions. So let's start with an overview of bioethics, because some of you may be asking, what's the big deal? Why are we even talking about bioethics? Let's start by talking about what ethics is, then we'll talk about what medical ethics is. I'll talk a little bit about bioethics, focus on global bioethics, and then finally, because my topic today is really to talk about public health ethics, that is what I will focus on. And hopefully we will finish this in good time so that you're able to ask any questions that you're able to ask. And I will also ask you to interact with me and answer some things on the chat. And I will definitely be offering some rewards for people who are willing to talk out there and just answer or raise questions in the chat. I'll be keeping an eye out for those who are participating. And when I get your contacts, I'll be able to send you something interesting in ethics that might pique your interest even further. So let's start with what is ethics to start off with. Now, ethics is really, you think about a branch of philosophy. It's about morality and moral principles, a lot of which we use in our everyday life. Fundamentally, people ask on a daily basis, what is wrong? What is right? What is good? What is bad? And I'm sure these are questions you're asking yourself, especially in this month of January when people are struggling with making the budget get to the end of the month and the month seems very long. You're probably asking very many questions. We actually make moral decisions on a daily basis, every single day. Ethics is about the quality of your decisions, not the number, the quantity of decisions you make. And ethics gives us a tool or a way in which we can make good decisions versus making bad decisions. And when we talk about ethics, we're really talking about how do we study values, principles, beliefs, and the things that become what we call the norm in our everyday life. What are values? These are things that are dear to us, things that we care about. And a lot of us care about these things without even thinking about it. We care about justice. We care about our families. We care about equality. We are concerned when people tell the truth and when they're honest and when they don't. And what are these based on? They're based on many things, including the societies that we live in, the religions that we may be part of, the culture that we live in and out. And sometimes they're based even on issues of law. There can be a conflict sometimes. For example, things like faithfulness versus caring. And sometimes what this helps us do is be able to determine what is good versus what is bad. When we think about principles, we are thinking about how do we determine an acceptable way to get things done? For example, do you keep your word? If you say you're going to be there on time, are you there on time? Do you bother to follow and keep your word if you have said that you're going to do something? So how do we select what are the values and what are the principles that we adopt? This becomes part of the basis when we're thinking about issues of ethics. How do you make a choice when there's a conflict between perhaps what you value and what your principles are? How do you decide what is good versus what is right? Is the one thing good with a capital G or a right with a capital R, or is it just good? So ethics helps us define the conditions under which we make choices. When you've done something that's inappropriate, perhaps you're overlapping and the policeman stops you. How do you make a choice for what's good versus what's right? So these help us determine the basis of what is available, and out of the options we have, what is the best option that you can take? So this started really with the Greek philosophers, people who would think about a lot of these things. And those of you who might remember your history classes, I unfortunately was thrown out of the history class early in my secondary school, something that I still regret to date. But the Greek philosophers really helped us think about these issues. And often they say that a life that is unexamined, in other words, if you don't think about how you live your life, then you really will not live your life to the fullest. So that brings us to ethics. What are we thinking about when we think about ethics? We're thinking about many different things, and we're going to explore that a little bit. I want you to think with me for a minute. We're early in the year yet, and I'm sure you're just starting to think about all the things you do, the work that you're in, wherever you're involved. And think about Timothy, who's one of your friends in a group of 8. Now, lately, he's withdrawn. He doesn't show up at parties, even though you invite him. Now, Timothy tells you that he feels he's going through depression, and he's been having some suicidal thoughts. He's thinking, the world can do without me. I don't even know why I'm here. But you suggested to Timothy that he should get medical help, but he's refused. He's not willing. Now, 3 days later, one of the friends that you have has a birthday party and invites all of you. You know Timothy has been invited, but Timothy does not show up. Now, at the party, people are having fun. They're eating their nyama choma. They're enjoying their drinks. We're all waiting for the cake cutting. And one of the friends say, you know what? Timothy doesn't seem to be interested in us anymore. Maybe we should just cut links with him. They ask you, what do you think we should do? Now, I'd like you to tell me in the chat, what do you think you should do? What do you think you should do? You know, because Timothy has talked to you. But everybody else is saying, you know what? Let's cut links with this guy. He's not interested. He's invited. He doesn't come. He doesn't show up. What do you think you should do? Can someone send us some responses in the chat? Should you agree with them? Should you cut off links with Timothy? Should you tell them something about what Timothy has said? What do you think? Caroline, is anybody giving us any answers in the chat, or are these people all quiet and not responding?
Well, I can see a hand up, but I don't think he can speak. Let me see if I can see things are really hotting up on the chat. Let me find out.
Well, people are asking some good questions about getting ethics courses. I'll tell you about them. Just hold your horses. I will tell you about courses you can get on later on.
Okay, so they're saying chat is disabled. Let's move down. Explain to them about depression and isolation. That's one answer. Ask the team to visit Timothy and discuss his absence. Suggest visiting him. No, we should not cut off links. Ask them to give him time. Keep reaching out to Timothy and encourage the group to do so as well. I would advise them to reach out to Timothy first. Some people are still saying the chat is disabled, but some people are already sharing. I think generally this is connect to him, share with a few friends, and give a surprise visit. Oh, surprise visit. Reach out to Timothy.
So really good suggestions, really good suggestions out there. Thank you, guys. Thank you for those excellent suggestions. Now, the big question here is, if Timothy confided in you, do you have the right to mention to the group that he's having a challenge? I like what some people are saying, reach out to him, encourage them to talk to him, encourage them to visit. But remember, when Timothy has told you what his personal issues are, he has not necessarily given you permission to share it with the group. And the fact that he's struggling, what's your ethical responsibility in that space? Should you tell somebody? Someone said, get him professional help. Can you get him professional help without his being willing to get the help? Can you force somebody to get help? Do they have autonomy? Do they have the right to be able to make decisions? So I can see there are many people here who definitely are thinking about these issues of ethics because you have some excellent suggestions. But remember, Timothy is an individual who has rights, but because you know information about him, and if you are his friend, you also have a moral obligation in terms of what should you do. So I'll let you stew and think a little bit more about that, and let's move on a little bit. So we've talked about ethics in general. Now let's shift it a little bit and talk about biomedical ethics. So this really starts very early, 1754 BC, with the Hammurabi Code that was a patient's right code. And it goes on later on to when we came to the Hippocratic Oath. I've heard some people, when they're not very happy, with those of us who are medical doctors, say it's not a Hippocratic, but that we are Hippocratic about it. In other words, we are hypocrites. But no, the Hippocratic Oath that many people have taken is really to talk about, can we do good? Because it talks about the conduct of doctors. Move fast forward into 1947, at the end of the Second World War, when there were atrocities that had been done by many doctors. But we highlight the issue of the Nazi doctors. They lost the war. And because of some of the things that had been done there to the individuals who were under custody, it raised the questions around research. Should people just do any research? Because there were some terrible things that did happen then. Trying to find out at what temperature would a human being need to be kept at if they were cold enough for them to die, for their heart to stop. And there were other really, really unmentionable things that were done, starving people to death. And the question was, should we do research, regardless of who this research is going to benefit, if an individual has not consented? Can we just take it for granted that, we need to find out the information? And the Nuremberg comes out of that at the end of the Second World War to be able to talk about, we must do research that is only necessary. We cannot do studies that do not take into consideration the welfare of the individuals. And even more, individuals must give informed consent, not just consent, but informed consent. They must know what are they consenting to. We moved on to the Declaration of Geneva that happened in 1948, and then thereafter in 1964, the Declaration of Helsinki from the World Medical Association that talks about how to do research, what the doctor's duties are, and what they should expect. That unfortunately did not stop the issues of inappropriate findings. And in 1978, as a result to a study that unfortunately is infamous because of what happens, the Tuskegee study, where there were poor sharecrop holders in the southern part of the United States who had been followed up for many years to be able to determine the natural history of the infection syphilis, but continued even after antibiotics, as penicillin had been discovered, never offered treatment. Many individuals suffered what we now know as secondary and tertiary effects of syphilis, children who were born as a result of being infected because their parents were never treated. And the Belmont report in the US was the one that came after that to be able to say, really, research needs to be regulated. We need to have ethics review committees. We need to be sure about what we are doing when we subject people into research. And this has moved on when we're talking about biomedical research to be able to say that in the practice of medicine and in research that is involving human participants, we must be able to ask the question, what is morally acceptable in the patient-physician relationship? What kind of treatment and care should be given to people, human patients or human participants who are involved in research? And can this be based on the use of moral principles that we apply in the practice of medicine? And remembering that sometimes there are principles that can be very hierarchical, and we need to make sure that these principles are non-hierarchical and that they do not have a conflict that cause problems for these human subjects. This is a book that you might want to be able to see, especially if you're interested in issues of biomedical research, because it's one of the ones that came out of these particular findings. So what were the core things that they talked about? They said, you know what? Every individual is an autonomous agent. We need to respect them as an autonomous agent who has the competence and the right to be able to choose. They must be given information and they must make decisions based on information they've been given, informed choice. We also said non-maleficence, do no harm. They should not have harm caused to them as a result of this. And beneficence, the duty to do good. There should be a benefit, and we must look at the benefit versus the risk. And then the issue of justice, that there should be fair treatment and there should be no discrimination and equity in as far as it is possible for every individual involved in research. So the 4 principles of biomedical research have then become these 4 on which we hang research and which we say should be achieved in order for research to be acceptable. This brings in the issue of even including law and the legal parts that must be able to govern issues of research. So let's think about this a little bit and think about it because I want to shift a little bit to thinking about a different area of research. Now, let's say you are the doctor in charge of the only hospital that has an ICU facility in a county. You only have 1 ICU bed that's currently available. We're in the middle of a COVID-19 pandemic, and there are patients who need ICU care who are arriving at the hospital within 5 minutes of each other. The first is a 90-year-old man who has late cancer of the prostate. Then a 38-year-old female who's a mother of 6. She's currently pregnant, expecting her 7th. The next is a 28-year-old newly married female engineer. And the last is the governor of the county, a 55-year-old male. So let's hear in the chat, who will you give this bed? And why will you give this bed to this person? Carol, please tell us what they're saying in the chat. Who will they give this bed? This person who's the one who has the power to give the bed to somebody. And why will they give it to them?
38-year-old woman who is pregnant. Somebody else says, first come, first served. Somebody else says the mother. The mother, because we are saving 2 lives. a few more saying they would give it to the 38-year-old. If you could just tell us why, it would also be great.
Great. So the 38-year-old now has two people voting for them. Someone has said first come, first served, so the 90-year-old man with late cancer of the prostate.
But I think the winner is the 38-year-old for now. There's somebody who's saying 28-year-old because they have the best prognosis.
At least they've given us a reason why.
I give, yes, to the pregnant, I would have saved 2 lives. So for a pregnant lady, the reason is that they'd have saved 2 lives.
Okay.
And they would have done good to the majority.
There's a philosopher,
Yes.
right?
The 28-year-old, because she's got more life left.
Okay. So those of us who are now in the older years, we'd better watch out. We don't have much.
Watch out.
That's not worth giving us.
But there are some people who still say first come, first served.
Someone says the governor can be flown to a different county. So no one's giving you priority. Oh dear. First come, first serve. Okay. So the question with the issue about ethics is part of the challenge is it's often not a black and white. And you can see from your chats in the response that people have such diverse views. And part of the challenge is not only having a view, but having a reason. What is the reason why you're going to do what it is you're going to do? And being clear on what that reason is. This is what bioethics is all about. So it was first used in 1927 by a German theologian. Bios meaning life, the relationship to, things that are living, animals, plants, and so on. And then ethics, as you well know, meaning life, the issue around bios and the issue of ethics, the choice, character, decision-making. And bioethics really applies to ethics that deals with issues from biological sciences and from the medical sciences. Now, unlike biomedical ethics, bioethics goes into beyond the patient-doctor relationship. It's really emerged in a response to the rapid biomedical knowledge and technology that we have right now. There's so much that's changing in our everyday medical lives: mechanical ventilation, dialysis, in utero fertilization, organ transplantation. And there's an increased awareness of what are the rights of any human being who's living today. And in bioethics, we're really going beyond biomedical ethics because we're thinking about what are all these things and how do we make sure that there's some congruence between all of them. So it's involved into an interdisciplinary field where we have philosophers, healthcare providers, lawyers, social scientists, biomedical researchers, engineers, biologists, all these different people trying to deal with it. And in contemporary bioethics, we're really dealing with the newer areas of ethical concerns, even as the issues of technology continue to advance. So let's shift it a little bit because I want us to think about the interaction and the interspace between not just human beings, but other parts of our world, because it's not just about us humans alone. We live in a world that has animals, where climate is being affected, and many other things. So let's look at this case study where you are consulted for an ethical opinion. The government wants to build a road. This will open up access to farmers in a remote part of the country, which, although it's very productive, the food products rot on the farms because there isn't lack. There's a lack of access to the foreign markets that they need because of the challenge of a road. So this has the potential to bring a lot of foreign currency by this produce being able to get out. However, the only available access is through a national park. And it will block access to the animals. It will not allow them to get their only source of water. You are giving this advice to the government. What advice will you give? And why will you give that advice? Why will you give that advice and what advice? Should they just build the road, block the access for the animals? If they don't get water, well, they will die. Or what would you say? What's your opinion? Some people are still responding and still giving first come, first serve to the government. People are still arguing about the pregnant woman. I'm glad there's such an active debate. All right. So Benjamin says you need more history. Carol, what else are people saying? What more history do you need? There's a road that needs to be built. You want to be able to ensure that the food that's being produced or the produce can get to spaces where it can go into the foreign markets and be able to ensure there's money coming in to the country because this food is getting rotten.
I am not seeing you. Where are you reading, Prof? I can't see where
I'm
you're
looking
reading.
at the chat. Frida has said, build it, but dig boreholes for the animals so that they can get water.
Mhm. So it's
Uh-huh.
not the Q&A chat, it's the other
No,
chat.
it's the other chat. They are in the other chat. Create
Oh, so
manifolds.
yes. Mm.
Any other suggestions you can see?
Yes, build a flyover.
Ah, okay. I like the flyover.
Build an underground road.
Wow, those ones are really
Yeah. Serve humans first, Prof. Humans should come first.
Uh-huh.
So a lot of people are saying that please build a bypass. Somebody's saying relocate the animals. Somebody's saying, yeah, build a different road. All are important. Find what works for benefit for both. Yeah. So some people really feel that there should be a road, but at the same time, they want to conserve the animals. So a bypass would do. Route the road or bypass. Build another water source.
Many suggestions. This is just to remind us that we live in a world where it's not us human beings alone, and we do depend on the ecosystem we live in, and there are issues of climate that also become important, and the other inhabitants of our world, not just humans, who need to be important. So let's briefly look at the issue of global bioethics, and then we'll focus on my topic for today in the last few minutes, which will be the issue of public health ethics. Now, just as you've talked about, build a bypass, build an underpass, do a lot of the technology that we may want to use, some of it we may have available, some of it we may not have. And if we were to build this bypass, if this case study I've just presented was in this country, we'd probably be going to either the Americans or people in the UK or the Chinese to help us build that bypass. So we realize bioethics affects us across the borders, and the COVID-19 pandemic brought that home in a very real way. Some bioethical issues can't be solved within borders. Global warming, air pollution, water pollution, terrorism, and of course, as we all now know, pandemics that spread like wildfire. So governments may not be able to make an impact unless they work within a global mandate. And so we need to think about other aspects of these biomedical principles, intergenerational. We are custodians of what we have inherited, and we need to preserve it for future generations. There's a concern around international social justice. There's a lot of poverty, exploitation, human trafficking, and even things like toxic dumping that all fall within this realm of ethical global ethics. So in order for us to have justice, we do need to be able to ensure that there's equity. Brain drain affects the health and the healthcare of many individuals within the global south, because we train, we ensure they're well trained and so on, and then they leave. And then we don't have enough healthcare workers. So there are many challenges that involve the global arena, that involve governments needing to work together. This was one of the things that was being discussed when we were in the midst of the COVID pandemic. The concern about when there were available potential treatments for COVID-19, and then a government would buy all of it. And so the pandemic was actually such that researchers conducted clinical trials everywhere to see what could be used. So results did show that there were some things that were useful. However, once the results were out, the US government took all the stocks of the drug, making it unavailable. Does this raise any ethical issue for you? Would you be concerned? Or is it like, well, someone said first come, first serve, when we're talking about the 90-year-old in ICU. So should we say again, first come, first serve? They had the money. They probably put the money into the research. So, yep, if they take all the available stocks, that's perfectly okay. What do you think? Was that accessible? Acceptable? Does it raise any ethical concern for you? Anything in the chat, Carol? Some may even be in the Q&A. Someone is very upset. They're saying it sounds like the Tuskegee trial. It's unethical, unacceptable, and unjust. Not acceptable. Why is it unacceptable? They had the money. They probably put the money into the research. Why is it unacceptable? Carol, any comments?
Yes, lots of them. I just have to keep going. It's unethical because, okay, equity should prevail. No country that can exist on its own. We all need each other. Public health emergencies are often used as an excuse to overlook ethics, not acceptable, but power play. Where is equity? Selfish, killing others. It's coming so fast and so furious, Prof.
Okay, people are unhappy. Clearly, they're unhappy because there was something that was very unjust. So,
yes.
Yeah. So we want to talk about public health and ethics. And I'm glad you're so unhappy about what you felt was done by one country that was a superpower and had the money, because this really does bring us to the ethical issues from a public health perspective. So when we're talking about public health, we move from an individual, but we talk about organized aspects of society. So public health ethics, we're really thinking about not just one individual, but we're thinking about prolonging life and promoting health through organized efforts. So what is it? It's systematically looking at balancing competing interests and providing justification for any public health policies or decisions that are made. We are looking at ethical issues that arise from being able to improve the health at a population level, not just at an individual level. So when you're thinking about individual health, you're really thinking about just the human rights, someone's civil liberties, their autonomy as an individual, the medicalized system, their own issues of confidentiality and privacy, and you're thinking about it from a personalized point of view. When you're thinking about public health and population health, you're really thinking about a utilitarian point of view. What are social and legal responsibilities? How do you protect the public health? What is the opportunity for the community to be oriented? What's acceptable from a universal point of view for accountability, or even for governments, what's acceptable from a government point of view? Think about it from this point of view. From an individual point of view, there's your personal hygiene. One assumes that you'll take care of yourself so that when you go to the washroom, you will wash your hands after you come out of the bathroom, that you'll take immunizations when you need them, and that you'll provide self-care to yourself, that you have the right to be able to get individualized care. You will choose where you want to go to, and you'll know or have the right to know whether it is you want to go to a certain place. You have the right to know, the right to die, the right for your privacy, and you have the ability to provide informed consent for what you want to participate in or not. When you think about it from a public health point of view, the public health has a concern. That's why we say, and I'm sure you've seen these signs in Kiswahili, usikojoe hapa. Please do not urinate in public. We don't want you to go around spitting in public. We don't want you to go around and smoke in public, because you're forcing non-smokers to also smoke. We think about immunization because it's not just your individual choice, it's a question of herd immunity. When we have enough people who are immunized, then we stop certain diseases from spreading from one to the other. It's a question of providing access to care, then you can make the choice whether you want to have it or not. Providing education, having a gatekeeper function, and then requiring some levels of mandatory reporting to keep the public safe. If we don't know there's a problem, people can't make public health choices about providing that care. Following up cases, when someone has had TB and is under treatment, if they default, someone goes to look for them, because we don't want them not to get treated, because then they may spread the disease to others, and then the other people become sick. It becomes a concern for all of us, not just one. How do we make sure that there are adequate resources for care? How do you make sure there's equity in access? How do we monitor certain special groups, especially those who might be minorities or might be at risk for one reason or another? Remembering during the COVID pandemic that there were clear instructions and that it became a responsibility. So the questions we ask in public health is, what is the responsibility with regards to the society? It may be a bit of a paternalistic approach, but then we have to be able to decide about your individual freedom versus the freedom that can be provided because it's a responsibility of the state to be able to be responsible for the public. And we ask the questions around, is consent mandatory as an individual when we're dealing with public health practice? Does an individual right override your social responsibility? For example, if we're contact tracing you, whether it's for sexually transmitted infections or for TB treatment or in the COVID-19 pandemic, are there precautionary measures that need to be taken? Well, must we prove that everything is useful or can be used in order for any new medication to be used? What are the concerns around equity and health? And is there adequate funding that is provided for the public health concerns? So there are many ethical theories and values that come into a play when you think about the issue of consequentialism, which thinks about what is the outcome. It focuses on the outcome, the consequences of an action. Someone who refuses to wear a mask, what is the consequence of that to others? Then we think about the issues of deontology that come in from a very high level, where we're thinking about the rights, the duties, and the intrinsic moral features and actions that make people act in a certain way. For each of these, we really have to come to it from a cause-related reasoning, okay, where we are thinking about what are the similarities, what are the differences, what are the decisions that we make based on this caustic approach. Ethical theories, especially in public health, really come to the point of view of thinking about what is the greatest number of individuals we can support. How do we do the greatest good for the greatest number of people? How do we ensure that we keep as many people alive as is possible? That is a utilitarianism point of view. And then when you think about it from an egalitarianism point of view, it's how do we ensure there is fair distribution of the benefits and of the burdens? This comes back to the issue of justice that was raised earlier from the research ethics of biomedical principles. When is it appropriate for individuals to be involved versus who benefits from it in the long run? So thinking from research and public health, research really emphasizes on individuals, the respect for autonomy, the liberty, informed consent, making sure that there's beneficence versus non-maleficence, and justice. But public health emphasis is institutions, populations, social determinants. What is the public engagement? What is the social good? What harms can come out of this? And where is it that we make sure that there is social justice? I want you to think about it from the point of view of public engagement versus informed consent, because it's very hard to get informed consent from the public. Who are you asking and who is giving that consent? So it's more around engaging the public so that they're aware and able to make decisions. And remember, these were some of the things that people were being engaged in when we were dealing with the COVID pandemic. We're talking about keep your physical distance. If you're sick, stay at home. Wear a mask, observe guidelines so that we were able to ensure that people could hear. We're not asking them for permission, but we're informing them and engaging them to ensure that they could make choices and decisions that would preserve their health and the health of others. So what are some of the challenges? Really, allocating resources that can be very scarce. This is especially in regards to special groups and as respecting individual rights while protecting the public good. How do we serve those who are hard to reach? How do we engage in information that may be difficult, but also in a transparent manner that allows them to be able to understand, but also protecting their data and confidentiality? During the COVID pandemic, if an ambulance appeared or a team of individuals wearing what looked like space masks, those white protective gear, then everybody knows if they're your neighbor, you must have COVID, that's why they've come for you. How do we protect while still conducting surveillance activities and protecting the public good? And especially when you're in the place of a public health emergency, something where the consequences have potential to overwhelm the routine abilities of the community to deal with them, then it became even more important. So in this case, we ended up with situations where it was really, really difficult. And as a result, decisions needed to be made, for example, on ensuring we could do what was called flattening the curve. How did we make sure that there weren't so many new cases where the pressure on the health system was such that the health system would not be able to take it, and many more individuals would end up losing their lives? And so there were things that were decided, like the lockdown. You were not asked for your permission. You were told. There were restrictions. Schools were closed, bans on social gatherings, or limiting the number of individuals. And the challenges people struggled with were, when you limit this, you limited people's economic activities. This made it very difficult. If I don't even have food to eat and you're telling me you want to keep me alive, how are you helping me in the public health space? So these were the challenges of public health decisions and public health ethics. How do you decide what would really be good for the individual, not just now, but also for the public health? Masks were an issue where people complained about, oh, it costs money. Where do we get the mask? People would run away when they saw individuals they thought were policing them and they were not wearing their masks. But really the mask was to reduce the risk for an individual, to provide protection for you and for the other person. It was made mandatory without asking you for your informed consent, to ensure that there was some amount of fairness, to reduce stigmatization, but also for the effective way of being able to reduce the possibility of infections passing from one to another. Really illustrating the challenges of the public health field. So it was a regulation for a period of time. And hopefully in the end, they did help. And then once vaccines were available, again, the question of equitable distribution. How do we make sure that there was adequate amounts of vaccines? And again, the high-income countries that had just 16% of the world's population bought the majority of the world's vaccine supply. And then the mechanisms that were put in place to help the low-income countries were struggling because there wasn't adequate vaccine quickly enough to be able to respond to the pandemic. So we think about the issues of, it's not just about fair and unfair, it's a question of, is it morally acceptable and is it morally defensible? So that we ensure that we are thinking about fundamental values of human well-being, equal respect, global equity, thinking about how we can ensure there is national equity, there's reciprocity, and there's legitimacy in the decisions that are made. This brings us to the place that in the public health sphere, we really need to be thinking about how do we openly share? How do we ensure that there was appropriate manufacturing technology that was available, that the issues of intellectual property could be quickly utilized to ensure that everybody could access and could eventually benefit from the research that was ongoing for the COVID-19 pandemic. So ensuring that there was waiving of intellectual property barriers, and also ensuring that there was appropriate expanding of voluntary contracting between manufacturers to ensure that there was actual available supply. So in the long picture of time, usually it takes us a long time to start from when we first understand a case happens, report it, animal experiments, basic research, and eventually to the clinical trials that give us the new medicines and products and investigational products that become part of what are in our healthcare system. But during outbreaks, these all needed to be condensed in a very short period of time in order to respond to these public health emergencies. So this is a trajectory of what has happened in the past with regards to research after an outbreak. But in the pandemic that we faced, it really changed over a period of time to make sure that during the COVID-19 pandemic, we could respond in really fast time. We learned a lot of lessons. Some of these were from the HIV pandemic, some of them were from Ebola, and some of them required that the timeliness of clinical trials, even in the midst of a pandemic, were pretty quick, and that we could start to think about using off-label products, so long as we could had enough data to be able to use it, and to ensure that we could also change the design of research to respond to these very, very quickly. So compassionate use is one where doctors are making decisions, because even if one isn't eligible for the clinical trial, they think that it would be helpful and they can make use of it. Beyond this, we went to what was called Maori, where we're talking about the use of medical products that could be used urgently. They were approved just within the state of being able to be used in this space of a pandemic so that they could be utilized without waiting for all the other information that we would usually have done, but monitored very closely to ensure that we could break this pandemic. So as I finish, the monitored of unregistered and experimental interventions became part of our public health emergency response. So that products that there was some evidence that it could use, that it could be useful just within the remit of research, but could be used to ensure that individuals could be kept healthy or could be helped within this phase of a public health emergency. So they are not used as non-research, but they were still used because there was enough evidence to be able to provide them with this use. Within this space, of course, there was also the importance of ensuring that there was the appropriate reviews within the medical health research, so that ensuring, and many countries now have laws, and we in Kenya definitely have the law, that we did do the appropriate research done within the remits of appropriate approvals within the research ethics committees. So as I finish and give us time to be able to talk, Carol, it's 10 minutes to 3, so I will finish on time. We've talked about what ethics is, what medical ethics is. We discussed bioethics in general, then talked about global health ethics, and I've just finished giving you a sort of very quick side view of public health ethics using the COVID-19 pandemic as an example. Some of you are asking, where can one get courses? There are current bioethics training programs in Kenya that are supported, many of them through National Institutes of Health from the US funding. There are Masters of Science programs and postgraduate diplomas. There are also certificate programs that we are offering at KEMRI, and we do advertise regularly for them if people want to be able to take those. Let me tell you a bit more about these other programs. Mount Kenya University is providing a program that's currently having an intake. They offer a master's program and a postgraduate diploma in bioethics. And I will provide these slides. I provided them to the host, so you'll be able to see and be able to look at their website and be able to respond. Amref International University is now taking a second cohort. This is their second year. They started in January last year going on, and they do have a master's program and a postgraduate diploma where they're also offering training in bioethics. There's a very important program that brings in the whole One Health aspect. The Master of Science in One Health that's offered by the University of Nairobi is also one that one would be able to take. And this brings in the holistic area of being able to think not just about human, but also think about emergency situations, but also One Health ethic. To close off, those of you who are interested in issues of ethics, the Bioethics Society of Kenya, I'm no longer the chairperson. Professor Muhudia, who will be speaking to you later on in the week, is the chairperson. This is an opportunity to be able to engage with issues of bioethics. It's another opportunity for you to talk about issues of ethics, talk with people who are like-minded. They're open to registration, and Carol had talked about the Bioethics Society of Kenya earlier when she introduced me. They do have a conference that's coming up in March, an opportunity for you to share information in ethics and be able to also engage. I'd like to thank you very much for being such a participatory audience. Thank you for all the individuals who are responding. And I'd like to take it back to Carol so we can take a few questions, assuming we still have a bit of time. Thank you very much.
Thank you very much, Prof. Pukusi. Wow, already I can see the thumbs up, I can see the claps, I can see the hearts. So I don't even have to ask people to give you a round of applause. Now, I don't know how we're going to do this. There are going to be thousands of questions, but we shall do our best to get to all of the questions that we need to get to. So it's question time now. Ladies and gentlemen, you are free to ask any question you'd like about what you've heard today, about general bioethics, about public health ethics, about things that are not ethical in your view. Ask, we are ready. My question is by Boniface: how do emerging technologies such as CRISPR gene editing, biomedical research, or AI in healthcare impact bioethical considerations? Well, that's a PhD in itself, Prof. But that's the
That is
first
a
question we have
PhD.
seen.
That is certainly a PhD question. I'd like to encourage the person who's asking it. This may be a very good topic for a PhD dissertation in a multidisciplinary project. But you're very right. You're asking important things, and these are the questions that we're asking. I know the universities are struggling right now with being able to draw parameters for individuals to say, what should you do even with regards to students in AI? We're already there. We can't get away from it. We can't pretend it's not going to happen. It's already a reality in the work that people are doing. We need to draw the parameters in terms of what's acceptable and what's not. What can people use and what can people not use? Already, I'm sure the doctors and the nurses and the clinical officers and all the different paramedicals are already facing challenges of individuals who Google everything first before they come to you. In fact, they come to you with a diagnosis and they want to discover, do you know enough to be able to treat them? So we do need to come to the issue of saying we have a lot within the AI space. It's useful. They're tools. A tool is simply a tool. How you use it is what matters. If I have a knife, I can use that knife for good. I can use that knife for not good. It's my choice what I do with it. So these are tools. And when you talk about gene editing and the CRISPR, it's a question of the tool. What do you use it for? And is that acceptable or not?
Okay. That is very true. And as you said, they are here with us, actually. They're in fact ahead of us. So the sooner we start thinking about it, the better for us. Prof. Muhudia did ask us to mention the certificate courses, Prof. So as people are continuing to think about what to ask, maybe you could mention the certificate courses.
Yes, certainly I will mention. We have certificate courses that we offer and we train at the Kenya Medical Research Institute. We have a certificate course in clinical ethics. We have a certificate course in public health and research ethics. We have a certificate course that is the fundamentals in bioethics, which really goes into the philosophy and people who'd like to do things about philosophy. That's one of the courses. And the fourth one is the certificate course in research methods. It helps you really get grounded and understand issues about research methods, because if the research isn't right and the methods are not right, that research cannot be ethical. It will not add value to the field. It will not yield suitable results. And so one must have a solid foundation of research methods in order to be able to do ethical research. We offer these free of charge when we offer them. Some are offered online, virtually. Others are offered in person. We have already circulated a poster for the clinical ethics certificate course that will be taking part, I believe, on the 26th of February. So right now we are receiving applications. We always receive many more than we can take. We take about 30 at any of those certificate courses. If we stretch it, maybe about 38. We get about 150, 160. So the sooner you apply, the better. They're very good for helping you get an idea of ethics, getting well-grounded. They help you even as a researcher or even as a student. They will be very, very useful for you.
Thank you. I see a number of people with their hands up. Maybe you could put your comments into the chat.
I think the host may also be able to allow them to ask questions. So the host can tell us who they are unmuting, and then they would be able to ask their question. Maybe it's a difficult one to type for long. So they can ask questions if the host enables them to. Okay. And thank you very much, everybody, for saying thank you. Thank you for being here. You are the important reason that we are here to be able to share this information. Thank you for being here.
Yes, Carol, and apologies, I didn't quite get you. You're saying something about the questions?
I said that there are some people who have their hands up,
and
I had said possibly they could just put their questions into the chat, but Prof was also saying if you could unmute them, maybe they would ask their questions, because so far I don't have any new questions. I'm just saying thank you.
Oh, okay. I'm looking at the hands. It seems I don't know, maybe some of there's one who's raised their hands. Would you like me to allow them?
Yes, that would be Odongo Opio. Then somebody else put up their hand and put it down again.
Okay. Go ahead, Odongo.
Odongo Odio, not Opio.
Oh, yes, indeed. Odio. My apologies.
Thank you so much. My question is actually what I put in the chat there. First of all, thank you very much, Professor Vukusi. This is wonderful. I was just asking, how prepared is our KMPDC in oversighting these ethical practices as a body who is mandated to ensure we observe good practices? If they are not well prepared, how do we help them to achieve these goals? Thank you.
Thank you very much, Odongo Odio. The Kenya Medical and Dental Practitioners Council is actually spot on right now. They have realized and they are looking forward to looking at more detailed issues around ethics, especially clinical ethics. We are very concerned about, we're very, very concerned about research ethics because it's very structured. But you know, clinical ethics does even more harm because there are more people who come into the clinical space for care compared to those who end up getting involved in research. Think about the question I was asking you about who makes the decision about the one ICU bed. And there were a number of people who said first come, first serve, and a number of people said the 90-year-old. It seems the majority were voting for the 38-year-old mother of 6. But who makes that decision? And when you make that decision, do you go back at night and sleep, thinking about what if? And so this is why we talk about the importance of ensuring, for example, and Kenya Medical and Dental Practitioners Council is talking about promoting, for example, hospital ethics committees that will help people make difficult decisions that nobody should really struggle making alone because it shouldn't be on your conscience. There should be a mechanism that allows for decisions, rational decision-making in terms of even deciding on resources and a way of being balancing out. Because every life does matter. And it's hard to say one life matters more than the other. But when you have limited resources, how do you make the best possible decision in that space? I'm aware that the council is currently reviewing its guidelines and its principles of practice, and they are taking into account very, very strongly the issues of ethics. They are also encouraging all the different universities offering medical training to beef up and improve the training of clinical ethics to the clinicians that we're training. And I hope this will also be true of the other cadres so that people can be made more aware. When I trained in medicine many, many years ago, there was so little that was taught on the issue of ethics that we barely, didn't know much about it. And you simply came out and learned. And then perhaps we were not very fair to the people we were treating, because so long as we were very well trained in terms of diagnosing and making the appropriate decisions, but when it came to communicating them, or when they were challenging decisions, like explaining to a patient who actually has a terminal care disease, we were not trained well enough to be able to communicate that. We struggled with issues like that. So they are taking that into account, and I believe that we will see some improvements in this field. But thank you for that excellent question.
Thank you very, very much. Hilary Koros.
The host needs to enable them to talk.
Yes. Yes, thank you very much, Hilary. You may ask your question, just unmute.
Hilary, you need to unmute yourself. You've been enabled to talk, just unmute.
All right, host, maybe you can try Stephen Olwach and Rael Koru. Stephen, go ahead. All right. Sometimes you're trying
Stephen
to do something.
Stephen has unmuted. Go ahead.
There you go. Stephen, would you like to say something? I can see it moving, but I can't hear his voice.
Can't hear either. Was there any more question, any more comment?
Many of them are requesting for slides, Prof, and for CPD. Yeah. But I don't see a question.
Okay. I see more questions about asking about CPD points, which I think they've been told where to get the information and where to ask from. So I think if they don't have any more questions. And I think hopefully we have done justice to this particular topic for today. And they can look forward to hearing more about research ethics from you and hearing about clinical ethics, which I think is a really hot topic, from Professor Muhudia later on in the year. So I'd like to thank you all very much. Thank you for being an excellent audience. I'm told there's a question in the Q&A. Okay, let me see what the question is. I think if you go to the Q&A, Carol, there may be some questions.
Yes, so there's one by Moses Minor who says, what happens if you have a cancer patient who you clearly know that the prognosis is not good and members tell you should not disclose it to the patient? What are the ethics to look forward to there?
That's a really good question. And I think we go back to the issues of principles. Remember, I was saying that a lot of times with ethics, it's not about just right and wrong or yes and no. Why? And that's why you need help. And that's why I'm talking about the hospital ethics committees, because the question is, why do the relatives not want you to tell them? This is a person who is autonomous, and is there a condition? Is there something else that's making them reluctant and not wanting to tell them? Do they fear that they will give up? Often people have more fear than even the patient themselves. And pretty much when you're really sick, many patients know there's something mortally wrong with me. And they may also even be worrying about it. We used to say in the early years, before HIV became a treatable disease, that HIV gave people time to set their house in order, because HIV did not kill you within a day, but people suffered. They really, really suffered in the process with emaciation, and they literally starved to death. Really, really painful. In the same way, sometimes when people have terminal diseases or cancers that are not treatable, it may be helpful for them, because the goal is, even if in medicine, even if you cannot cure, medicine aims to be able to provide a reversal of whatever condition someone is suffering from. If we can't reverse it, we hope to rehabilitate so that they continue with normal function. Sometimes even those two are not possible. And if those are not possible, how do we ensure that someone has a quality of life that is comfortable? Because we may not be able to add them longevity in terms of life, but we can add them comfort. We can let them know they're still valuable members of society for however long it is that they're still here with us. And helping someone work through that process, helping their family work through that process, is very important. Just because someone has something that's terminal doesn't mean they're dying tomorrow. We don't know when their life will come to an end, but we can do whatever we can within the process of palliative care to ensure that the number of days they have is not only prolonged, but that the quality of life that they have is also made in the best possible way.
Right. There's another question here. In the current era of social media, we share lots of patient information on social media amongst ourselves as healthcare workers. What is your take on that?
If anyone shares my personal information on social media and I find it, I will sue you, or I'll take you to the council. That's on a light note. The reality is, if we do not have patient permission to be able to utilize that information, then that's not appropriate. Sometimes there may be something very little that would allow someone to recognize who that person is. Put yourself in their shoes. Would you want someone to share that kind of personal information about you? So this is where ethics comes in, and Professor Muhudia will be talking more about clinical ethics, and hopefully we'll also touch on some of those issues around social media. What can you share? What can't you share? And the challenge with social media is you have no control over things once you have set them out there. And then sadly, social media doesn't forget. Once things are out there, even when people say deleted, someone can go back and find it somewhere. Therefore, there is that need to be cautious and to be very careful about what you share. And if you share it, who are you sharing it with and for what purpose? Sharing a picture or perhaps a dermatological condition for which I'm seeking advice and seeking information that would help me treat someone may be very appropriate. But again, I needed to have told someone I may get additional advice, especially in the area of telemedicine. But if not, then you really need to be careful, because these are things that can come back to haunt you and can come back to cause you challenges in your medical practice if you're not observing in an appropriate manner issues of ensuring that you are maintaining people's confidentiality and also maintaining issues of privacy even when you engage with them.
Okay, that's a good good place to start. Although, of course, things can be very tricky, but that's a good place to start. There's another question. Do we consider traditions? I suppose these are cultural traditions, Prof, in ethics? And if yes, how does the community participate in ethics establishment? Wow.
Difficult, but very important questions. Indeed, we should, and indeed we must, because we live in a world where we have cultural things that we bring to the table and cultural underpinnings by which we live. So this is a community engagement is a critical part of ethics, because people are community, part of community. So you can't sort of just separate ethics away from the rest of what human beings are. So how does community get engaged? Engaging the public is a very important part of ethical discourse. Remember, I'll take you to the research ethics field, where for any research ethics committee to be legitimate, you have to have a community member or a lay member, someone who represents the basic non-biomedical, non-professional, in that sense of the biomedical worldview, and who can ask the question of, would I want this to be done to myself or to my neighbor or to my child, and is able to bring that very human, non-biomedical tint into the research lens.
Mm-hmm. Excellent presentation, Prof. Bukusi. In COVID-19, vaccines had some side effects which became apparent in some cases with mortality and some with long-term effects like SLE, etc. From a bioethics angle, do they bear some responsibility for compensation?
Great question. The question would be, were people given adequate information prior to their getting the COVID vaccine? Did they know what the potential side effects are? This doesn't only apply to the COVID-19 vaccine. Any biomedical intervention, there are side effects. And if you look at any interventions we have ever had, for even the simplest of things, there are side effects. Do we necessarily mean that people need to go back and get compensation? It depends on whether information was given and whether people are able to ensure that they took that in good knowledge of what they were getting. But think about it from the other point of view, because what also happens is people forget. You may have had a number of individuals who died, and every life was important. How many other lives were saved? We often take the one where something happened and blow it out of proportion. And I always think about this because I come to the table with an OBGYN lens. The one woman who has an IUCD and ends up getting pregnant, you hear more about it than the millions of women who use IUCDs and never get pregnant. So there is a question of compensation. There is a question of adequate information. And there's also the question of how much good. Remember, we're talking about public health good. The public health good that has been done versus the potential harm that could have been done to some individuals. But did they have the knowledge? Did they have any information? And is there adequate resource towards helping them from that point onwards?
Next question is, how do we roll out ethics to the grassroots health centers? Issues of professional negligence are rising.
Well, Jocelyn, I think this is one of the good ways that the KH platform is enabling people to have information that allows them to be able to make choices. People do need to know, especially professionals need to know so that they can take appropriate actions. So holding people accountable so that you're not just, think about even the ward rounds that people do on a daily basis. You're in a ward round, you have two people in a bed, you're talking about their cases. You're providing their information without their choice and without their decision-making to the public, to other people who are around them. So being able to ensure that we can have an ethical approach to our clinical work, to our research work, to the public health work that we do, that this is all very important. So making awareness, this is the first step towards ensuring we can do things ethically. But remember, just knowledge doesn't make people ethical. It is said that if the philosophers were all very ethical, we'd have an excellent world. Just because they're philosophers doesn't make them ethical. It's a question of choices that people make. Beyond knowledge, it's your character and your decision about what you're going to do with that information.
What is the relationship between ethics and governing bodies?
Governing bodies, it depends on which governing bodies you're referring to. In as far as research ethics is concerned, there are now very clear decisions that have been made. There's a law. If you do research without a permit, you can be jailed. That is the reality. So don't do research without getting the appropriate permits from your research ethics committee, from Pharmacy and Poisons Board if it's a clinical trial, and eventually also from NACOSTI. Otherwise, you will get into trouble. You can be jailed. You can get into trouble. In as far as other cadres of clinical work are concerned, I think each of the governing bodies, whether it's the clinical officers, the nurses, the physiotherapists, the Kenya Medical and Dental Practitioners Council, they do have rules and regulations, and they have guidelines that will tell you. And if you go against their guidelines, then you can be taken to book, and your registration and your processes can actually be brought to a halt if you're not following appropriate regulations.
Okay. What would be your comment on DNI, DNR, and de-escalation of care?
That is a whole lecture in itself. What I will do, I will ask one of our palliative care specialists who's also trained very well in bioethics, Dr. John Weru, Professor John Weru of the Aga Khan University. I will ask the KNH research team to allow him to come and talk about palliative care. And that will be a very good entrance for you, just understanding the issues about how do you make decisions about long-term care, the do not resuscitate, the decisions about what people want to do with their lives and their choices. So we'll make a plug for him to come, because that's a whole talk on itself.
Indeed. And tomorrow, perhaps Prof. Mhudia can touch on it. Also, there's a question about the bed and the 90-year-old man. I think if you were to listen to Prof. Mhudia tomorrow, you might get some better view of it, but also that's why we have hospital ethics committees. Let me see. Just give me a minute. Nowadays, a lot of health concerns raised by people, especially women, are linked to the COVID vaccine. Now, while vaccination was aimed at greater public health good, what ethical issues arise by virtue that there could have been some long-term side effects that were potentially expected but overlooked because of the urgent need to get the masses vaccinated? I've read it again because it seems to be a recurring question, Prof. This whole idea of side effects.
I would say one of the things we need to remember is nobody knew what all the side effects were because they hadn't been used for long enough. And that's what we need to remember. Some side effects you don't know. If I take medicine for a week and side effects that are going to appear in a year's time, nobody can know whether I'm going to have those side effects or not. So there are some things that only time will tell. And indeed, this is where the challenges of public health ethics, that there are some long-term effects we will not know until we get into that long-term. And that long-term is going to take us years. The question we still need to answer is, when we do find those long-term effects, how will we balance them versus the fact that this person stayed alive and did not die as a result of being infected with COVID, but now they have a lingering long-term effect that they need to deal with. How do we, in the public health domain, help them be able to deal with that? So that's the question that needs to be answered.
So we should be thinking ahead, really, and looking out for it. Yeah.
Because nobody could tell side effects that are going to happen in a year's time when the vaccine, people had not been followed up for a year.
True. But it could be maybe a couple of years now since they rolled out the vaccine. So maybe 2024, we might have more information about it, especially if the phase 4, where we collect data from people in the field. If that information can start pouring into PPB, we might have some good idea. There's a question here, Prof, which I don't know how you're going to answer. So this is somebody called Fahim Khan from Pakistan. And he says, may I ask from a research ethics point of view, we struggle with maintaining ICMJE criteria from IRB perspective in Pakistan. How have you addressed this in Kenya?
I guess we have a lot of researchers in Kenya, but thank you very much for that question. I think the question what you're asking is the IJCMC criteria that talk about in order to be to qualify, but it's really broad, that you should be able to criteria that means you either had the ideas, you're part of the data collection, you have contributed significantly to the writing or the analysis of the results, the writing, the revisions. If someone doesn't meet all that criteria, then I'm not sure why do they want to be an author to start off with. But if you meet enough of that criteria, there shouldn't be any reason why you would not be an author. To me, the bigger challenge is usually the time and the effort it takes to actually write and put down your paper. And a lot of our training in low and middle income countries, while they allow us a little bit of training in terms of talking and discourse. They don't train us rigorously in the art of writing. And so our writing sometimes doesn't end up being as good as it could be, even though our scientific knowledge and our thoughts are as excellent as anyone else's in the world. So I would say it's the opportunity to really think through and be trained to be able to write well enough to be able to put your thoughts on paper. But if you do have those thoughts on paper, put them down. And if you do want to publish, be involved in the research so that you can meet that criteria and then be able to publish.
Yes, that's a good question for me in Pakistan. Maybe also in this webinar series, we can talk about research integrity and authorship. It is a big issue, and sometimes researchers want us to deal with it in an ethics committee situation, which would be a bit too much, would be having a lot of mission creep, for us to be able to say that so-and-so should be the first author, second author. That is really beyond the purview of an ethics committee. But thank you for raising that question. And thank you, Prof, for answering. There's a question, do professional ethics impact on organizational behavior?
Ideally, they should. Ideally, they should. But the biggest issue about organizational behavior, I would say it comes from, I would link it to a saying that they say, fish rots from the head. Mm-hmm. Leaders of organizations truly determine what an organization is going to be. And they determine the culture, they determine the ethos, the ethics. They really determine what that organizational behavior is like. So yes, you can lead from behind, you can lead even when you're not in charge, but a lot of organizations, it's the person who's leading it who truly determines, or the leaders within that group can truly influence the direction of how an organization behaves. And organizational ethics is another whole branch of ethics that is very important.
Yeah.
Carol, I guess one question here I want to respond to, because someone has asked about, they've said, we've talked about innovation and technology. They want us to adopt this in the bioethics certificate courses because we keep asking people to apply and send in information, and they apply because, they want us to save them time. I would love to save you time. However, the challenge is we don't know whether you're available. If you applied for a certificate course that we offered last year in September, and now we're offering another one in June, let's say June, or we're offering one in February, how do I know that you're available? How do I know that those dates are suitable for you and that you'll get the permission from your employer or whoever you work with to be available? Because we say we want you to attend 100%, to free you up for that 1 week so that you're available. I have no way of telling that you're actually available to be there. So if you're, and then be able to send them in. But I have no way of telling whether you're available or not when we offer a new course.
Yeah, thank you for that answer, Prof. I had not even seen the question. Right, so we're not too many questions left now. There's one that says, there's somebody, why does medical ethics allow the staff not to reveal the status of an individual, especially when it affects the other partner? I guess this is in terms of HIV, and this has led to children losing both parents. He doesn't think it's right. So would you like to comment on that?
It's a real difficult one. I don't know. You are in that position. I don't know whether you'd want someone to release your information without your consent. It's a difficult decision. And this is why we say it's a discourse. It's not about black and white, right and wrong automatically. It's a discourse. If someone doesn't want their information revealed, the question should be, we need to find out why. What are the barriers? What are the circumstances? What is it that's making it difficult for them to want their information to be known? Now, I've worked in the HIV pandemic and lived in it long enough to be able to see what some of the challenges were. I was a fourth-year medical student when HIV was first diagnosed in this country. There are women who later, for example, when I was an intern, would be diagnosed as being HIV positive, would go back home, would disclose their status, they would be kicked out of the home. They would have nowhere to go to. So it's a challenging issue around, do you disclose or not disclose? The most important thing is to be able to understand, why is this person afraid of this information being disclosed? That's why we have, for example, partner-assisted notification. Can we help them be able to disclose this information? That's why we have partner testing services. Can people come and be tested and know their status together so that it's an easier way of them being able to find out and being helped to manage, so that even if one is positive and one is negative, we have a way of being able to say to them, you can go on PrEP, you can start your antiretroviral treatment, and both of you can live your lives to the fullest possible, getting medication so that you are okay. Find out what is the challenge, not just, if you don't want to tell, I will tell them. There are many, and someone asked about the issues of culture. There are many cultural and societal and social issues that make medical interventions very challenging. So we have to deal with it within the context of the social and cultural situations we have. It's important that we take that into account.
That was a difficult one. And for many of these questions, Prof is doing an excellent job in answering them. But when you're there on the ground by yourself, it's a difficult thing to answer. Sometimes there's no good answer, and you might answer the question and somebody's still not happy with what you've said, or they still feel that you've done the wrong thing. I don't know if ethics means that you'll always do the right thing, but it does certainly mean that you will know why you did what you did. You may have gone to a principle, you may have gone to a theory to back up what you've said. So you can say, I'm doing this because in the best interest of, or you can say, I'm doing this because I am respecting the autonomy. So I'm not going to say it because I'm respecting the autonomy of the person who has disclosed to me. But you might also decide that it is not a beneficial thing to do. So say in the interest of beneficence, doing good, I feel I should disclose. So with ethics, it's not that you have the correct answer. It just means that you know why you have done what you've done, because you've based it on a principle or on a value, and you just keep going on like that. And sometimes people are happy with what you've said, and sometimes they're extremely unhappy with what you've said. So I'll ask the very last question now, that says, how do you balance ethics with common good in a public health emergency with regards to testing, disclosure, suspension of rights? And I guess this is the place to stop, because public health does have that issue that it tends to tread on people's toes as it's trying to go towards the public good.
That's a great question for us to end on. It's not about one person making a decision. And this is why we have groups and we have committees, when we have individuals trying to come together to make a decision that would be best. So it's not about one person. It's about a number of individuals. So we hope that when a committee meets and deliberates, and as Carol has just told us, it's about debating and agreeing and deciding and having good reasons for why you have made those decisions. Remember when in the first parts of the COVID pandemic, you had to come and you had to be confined to a hotel that the government had chosen, and then you have to pay for that hotel. It was very difficult for people. And later on, they were able to relax the rules and then make it more manageable, so that people will make decisions and that these will evolve with time. And the decision we made yesterday may not necessarily be the most suitable today. We may rethink it tomorrow, but it's in that continuing discussion of trying to ensure that we're doing the best thing for individuals, also for groups, and that we are balancing them in some way. It's not an easy task at all, but we have to be able to do it because there isn't any way out. When these public health emergencies and these public health situations come out, someone has to be able to rise up to the occasion and try and make decisions that will hopefully save the lives of the majority of the people. And for the individuals whom it inconveniences, hopefully it will not inconvenience them too badly to make their lives untenable moving forward. Thank you very much. And thank you all for being such a great audience. It's been a pleasure spending this last hour and a half with you. Back to you, Carol.
Thank you. Thank you very much. So you've seen the poster for tomorrow's presentation?
Thursday, not tomorrow. Thursday?
Thursday, sorry. I got that wrong. Thursday's presentation, and that will be Prof. Stephen Muhudia, who is going to take us through clinical ethics, and Prof. Elizabeth Bukusi is going to be the moderator. These are really giants, but let them be together. And the last presentation in this series that Cambridge is doing would be on Friday, where I'll take you through research ethics, and Prof. Elizabeth Bukusi will be the moderator. So thank you very much, ladies and gentlemen. It's actually 2 minutes to 3:30. Thank you for your attention. Thank you for your questions. Thank you for your participation. Thank you very much indeed. May you have a great evening and a wonderful week going forward. Kwaherini. Or can I say over back to KNH? Maybe KNH wants to say something, the host. But bye from me.
All right, thank you so much, Prof. and Caroline. It has been a pleasure hosting you, and we look forward to the next sessions that are coming up. I'd just like to mention there was a couple of queries on CPD. You, as instructed when the meeting began, you kindly send your queries or follow-ups to knhcpd@gmail.com. Our team will be able to pick those up and be able to assist you. Thank you once again for joining us. Do have a wonderful afternoon.